All right, welcome. I want to see if you can see the image on the screen. Hemi, can you see the image on the screen?
Yeah, I can.
Okay, perfect. All right, so let's start our webinar. Today we are going to review our first lectures and going to make highlight. This is not the purpose of this is to make a review of all the information that we already collect in the last few weeks. So what I'm going to do is to remark about some topics. All right, so let's start. Okay, so first of all, we need to remember the division of the respiratory tract in what is the upper and the lower respiratory tract. The importance about this, as we explained in the previous lecture, is that the treatment, the pharmacological treatment, is going to be different for upper and respiratory and lower respiratory tract. Lower, keep in mind, pneumonias and upper respiratory tract colds, for example, flu. The flu is upper, but they can develop into lower respiratory tract. So they can lead into pneumonia. But the upper respiratory tract is going to involve the laryngitis, for example, tonsillitis, the tonsils that are included in the oropharynx, and the nasal cavity, rhinitis, for example, and some complications that are going to be connected with the upper respiratory tract. That is the middle ear, infection of the middle ear, and the sinusitis, the sinus cavities in the cranium. All right, so let's keep going. So here in this picture, just to remember about the goblet cells. The goblet cells. Something in addition I want just to talk here is that the goblet cells are going to increase secretion, right? This secretion is, they are going to be affected by cholinergic effect. Cholinergic effect, cholinergic effect is going to increase the, for example, the saliva, and they are going to increase the mucus of the bronchi. If you have asthma, for example, and you have irritation, the goblet cells are going to produce more secretion. So one of the treatment is going to be, for example, ipratropium, that is an anticholinergic that is going to make dry the secretions. Okay, so let's keep going. And the same main signs and symptoms: congestion, cough, and mucus. And that is what we are going to have a summary about this. For example, we have the expectorant. We are going to have antitussive. We are going to have mucolytic. When you have increase of mucus, you're going to have the expectorant, antitussive, and the mucolytic. Congestion, decongestion, antihistaminic. And bronchi, for example, you have bronchoconstriction, you're going to have bronchodilation with albuterol. One of the things I want to remark is albuterol is for acute situations. It's not for is immediate action of albuterol. So in acute or crisis of bronchospasm, they're going to use albuterol. Methylxanthines is going to be used when they're not going to make effect other medications. Anticholinergic, sometimes they are being used to dry the secretions. Anti-inflammatories, we have steroids, the corticoids, especially we are going to use the glucocorticoids, that is the cortisol. Leukotrienes, that is the leukotrienes are going to be part of the prostaglandins. These leukotrienes are going to participate in an inflammatory process. Cutting the leukotrienes, they are going to be diminish inflammation. And cromolyn is the mast cell stabilizer. Okay, so decongestants. So to summarize here, we are going to use the pseudoephedrine, that is the alpha-1, right? Alpha-1, that is a vasoconstrictor. We have antitussive, we have the dextromethorphan, we have the mucolytic, is the acetylcysteine, antihistaminic, the Benadryl, Claritin, and the expectorant, the guaifenesin. All right, so one thing I want to remember is the difference between mucolytic and expectorant. Mucolytic is the expectorant first, the guaifenesin is going to bring more fluid into the mucus, make it more more watery, more easy to get rid of from coughing, right? So expectorant guaifenesin make more fluid in the mucus, and the mucus become more fluid and it can easier to go out. Meantime, mucolytic acetylcysteine, what it's doing is to break down the protein that is included in the mucus, that is the mucin. All right, so anti-inflammatories, we have the fluticasone, steroids. So these steroids are going to be for prevention, right? For prevention. These steroids are not going to be having a very fast action. Leukotrienes, they are going to be the montelukast, roflumilast, and these leukotrienes and the steroids, they are not going to be for acute process, neither the mast stabilizers. So all these guys, you can write down in your PowerPoint that they are going to be for prevention or long maintenance of the recurrency of prevent the recurrency of asthma attacks, for example. Bronchodilators, we have albuterol. The albuterol is very fast acting. Anticholinergic is going to be, remember, giant cat contraction of the cholinergic contraction. Anticholinergic produce the opposite, the relaxation. Methyl somethings is the theophylline, as we are going to see now. So again, here is what we must remember. So the pseudoephedrine, the congestion, alpha-1, that means vasoconstrictor. Antitussive, dextromethorphan, we are going to use when it's a dry cough. When it's a dry cough, when you have during the day and you're coughing and you have moving secretions, it's not desirable to use antitussive. Why? Because it's going to prevent the expectoration, the elimination of the mucus. Only when you have dry cough or when you, for example, are sleeping, you cannot sleep, you can have some antitussive. Mucolytic, dissolve and liquefy the mucus. Antihistaminic, remember antihistaminic, antihistaminic, we have anticholinergic effect too. So anticholinergic, antihistaminic are having the same similar effect. So we are going to see that in a few moments. So Benadryl, Claritin, so this is over the counter. You see here that these have more side effects, machinery, ask the patient not to do physical activity, or when they are driving, etc. So Benadryl can produce drowsiness. Loratadine has less side effects, that is second generation. Guaifenesin, expectorant is the guaifenesin is an expectorant. So they are going to come together, for example, the dextromethorphan and the guaifenesin, and that is different presentations. That is the robitussin. Bronchodilators, we have again, I want to repeat that albuterol is used for acute process, period, acute process. We have other ones that are going to be bronchodilators, for example, the indacaterol, that is the LABA, the long-acting bronchodilator agent. We are going to see that today. It's very important. Okay, so let's keep going. So upper respiratory tract, what I want just you to remember is this. There is two main situations, right? So there is other many, but there's the most common cold and rhinitis. When you have rhinitis, that rhinitis can be for allergies, right? So you have some dust or some pollen, whatever, you are going to have this reaction of release of histamine. And when you abuse of these vasoconstrictors, they are going to be called rhinitis medicamentosa. That is very important for NCLEX, and we are going to see that now. Allergic rhinitis, what we need to remember is that we need to use antihistaminics. These antihistaminics will be taken about 45 minutes before the exposure of a known allergen. Example, if you go to a trip and you're going to have some exposure to pollen or another dust, you need to take it 45 minutes before. Okay? So the antihistaminics, what is the mechanism of action of the antihistaminics? Is going to block the receptors of histamine. Remember, it's going to block the receptors of histamine. So the implication about this is this, that if you wait until you have the allergic reaction and then after that you take the medication, the antihistaminic, that is not going to make so effective, because the antihistaminic is going to block the receptors. It's going to block the receptors, but it's not going to diminish the already existent amount of histamine in your body. So this histamine is going to keep acting, producing vasodilation, congestion, and when you take antihistaminic, that is not going to go down or diminish, because the antihistaminic effect is to block just the receptors to produce more histamine. So the already existent histamine is going to still there. All right, so here we have when you have sneezing, we already talked about that. When you sneeze, mostly you can say histamine, and that is what you produce the process. All right, so let's keep going. Rhinitis medicamentosa. Rhinitis medicamentosa is a medication where you are going to use, for example, phenylephrine, pseudoephedrine, and for drops, nose drops, you can get use from that. If you use it more than 4 or 5 days, you're going to have a rebound effect. Please, rebound effect. And I'm talking about nasal drops. Nasal drops can produce rhinitis medicamentosa. That means that you create tolerance, and this make you need more and more and more of these nose drops. So patients can take it every 6 hours at the beginning, or every 4 hours, or then start to have every hour, even every 15, 10 minutes, they need to have at least one of these drops. So if, what is the treatment for this? And this is related to the topic, is to suspend completely the drops and to start corticoids, okay, corticoids. The pill forms of decongestants do not have this rebound effect, or very rare. The only one who you need to be careful, or mostly careful, is with the drops, okay? All right. So we have the common cold, and common cold, one of the favorite questions for NCLEX is the anosmia. So you already know, if you have a cold, you can tell yourself what are your signs and symptoms of a cold, right? And that is going to be rhinorrhea. You need to know the definition of all of these. And one of the things that they ask you very much is anosmia. Okay? All right, so for treatment of common cold, decongestants are going to be the most effective agents. All right, so complications. So if you have some cold, this cold, if it's not being treated, is going to lead into, is going to travel through the connections that are into the nasopharynx. The sinuses, for example, the sphenoidal, the maxillary, the frontal sinuses, that, remember, we was talking about, that is some cavities in the cranium that diminish the weight of the cranium and is going to help for the phonation. Well, these are connected to the nasopharynx. So the bacteria or virus, they can get into these cavities and produce sinusitis. Otitis media, remember we was talking about the station tube. That is where upper respiratory tract, the bacteria that can go into that area. All right, so here for a med search, so sinusitis. So the one thing that you need to remember is that it produce facial pain, facial pain. So you touch with your fingers in the area of the frontal of the maxillary, just gently you see and compare one side to another side, you will see that there is trigger out pain, trigger out pain. Okay. Another thing that this, what is asthma? I know that you're doing respiratory problems and you need to know the obstructive versus the restrictive. Here, asthma is the obstructive, so the problem of asthma is to exhale air, not to inhale, to exhale air, right? So if you cannot exhale all the air, what happens, you don't have a space for new air coming in. So that is asthma. And what happened with viruses and cold, they are can exacerbate the process of asthma. Okay? All right, so let's keep going. Here are the sinuses that I was just mentioned. So they are connected. They are totally connected to the nasopharynx. So this is, for example, the maxillary. We have the sphenoidal, ethmoidal, and here we have the frontal sinuses. Ethmoidal, sphenoidal here, and so if you see here, these are cavities. So when they are blocked by congestion, these are going to accumulate fluid inside. This fluid in 1 or 2 days are going to get infected because it's not moving and produce sinusitis. All right. So that is about that. We are going to see a more, so you already talked about the phenylephrine, that is the alpha-1. Alpha-1 is vasoconstrictor. That's all what, one of the things we need to know. One important thing, this is a nursing consideration and you must know this, is that they can increase the glucose. So alpha-1, what it's going to do is that increase the glucogenolysis. That means the production of glucose from proteins, for example. And this increases the glycemia. What is the nursing consideration here is in diabetic patients. So you cannot give it in diabetic patients. Another thing that you please need to remember is alpha-1 is contraindicated in patients with diabetic patients, be careful with that, and people who has hypothyroidism or people who has glaucoma. So this alpha can, or hypertension, right? Hypertension, glaucoma, diabetes, hypothyroidism. And this alpha-1, even that is topical, I mean, could be nasal decongestant, they can produce systemic effects. Hypertension, right? So if you have alpha-1 vasoconstrictor, they increase the peripheral resistance, increase the blood pressure. All right, so let's keep going. So that is about alpha-1s. We have beta-2, and you can see it's beta-2 agonist, and the beta-2 agonist, the one that we are going to talk is the albuterol. And we have the long-acting beta-2 agonist, LABAs. So this is albuterol for short, very fast-acting, and they are going to last about 8 hours. Meantime, LABAs, that is another group of the beta-2, are going to last about 24 hours. And for this, that is what we call the indacaterol. Okay, so this is a summary of the previous we was talking. Let's talk about alpha-1. We have ephrin, the oxymetazoline, that is the prototype. Pseudoephedrine, another one. See if you see pseudoephedrine, phenylephrine. So those are over the counter, and these are having some effect of alpha-1 vasoconstrictors. Okay, so here we have the pseudoephedrine again, that is going to can produce adrenergic effects. So alpha-1. So alpha-1 is adrenaline, right? So you can have, for example, tachycardia, your heart rate going up, hypertension because the peripheral resistance increase, careful in diabetes, right? And hypothyroidism. So please here, hyperthyroidism. I was saying hypo is hyperthyroidism. Hyperthyroidism. All right, so hypertension is the side effect of this. We already talked about that, is the increase of the peripheral resistance. Okay, so this picture I put it upside down just because I put it this because you should administer, you know how to administer the nasal drops, not like this, but like this. Okay. All right, so let's talk about antihistaminics. Antihistaminics, remember a few things. Number one, you need to take it if you know some allergens are going to affect you, 45 minutes before. Second, they they are going the antihistaminics if are given for example some rhinitis. If they don't respond, you need to change to corticoids. And the second one, antihistaminic, and the third one, antihistaminic, that we need third point that we need to remember antihistaminic is that they have anticholinergic effect. So they have anticholinergic effect. Anticholinergic effect means that is drying. Remember, please listen. Cholinergic is wet, right? Drooling, urinary incontinence, fecal incontinence. That is cholinergic. But here we have anticholinergic that is going to make dry, right? So why we need to be careful, especially with adult, with elderly, and with children. Why? Because if you have a expectorant and you have mucus, if you give anticholinergics, like for atropine, for example, they are going to dry the mucus. If they dry the mucus, can you expectorate them? No. So this mucus, what is going to happen is going to be like a culture for bacteria, and that produce an infection. Okay. First generation, second generation. In NCLEX, they're going to give you the name and, uh, and and probably you need to know if this is first generation or second generation. The most common is Benadryl. If you see the name Benadryl, B-E-D, like a capital case, is going to make you to put in bed, to sleep, bed, sleep. And DRY is dry, so it's going to dry. So that is telling you, just a way to remember that the Benadryl is going to dry secretions. Okay, so be careful with that. If you give antihistaminics to a person who is having mucus, you need to give with a lot of fluid. Okay, the correct amount of fluid a day. All right, so drowsiness, that's what we was talking about. All right, so it's more effective when taken to prevent. We already talked about that. Take it 45 minutes because the mechanism of action of the antihistaminics is to block the receptors of the histamine on the cell. So more is going to stop the production of new histamine, but it's not going to block the already histamine traveling in your blood. Okay. All right. So that is the first thing about antihistaminics. We are going to talk about the anti-inflammatories. We have anti-inflammatories. We have the Beconase, fluticasone, or casone, sorry, on. So those are actually corticoids. Corticoids are going to be corticoids. These corticoids, what is common adverse effect is the nasal burning. So what you need to do is to tell the patient it's going to burn. Golden seal is used for common cold, okay, but we are not going to use, is contraindicated in, for example, pregnancy and cardiovascular disorders because produce vasoconstriction. Okay, so no in pregnancy, no patient who has hypertension or problems with their heart, don't have acute or chronic GI disorders because that is going to that decrease the effectiveness used for decrease the gastric acid. So the gastric acid medications are not going to make effect. Lower respiratory tract, we have, these are, all are obstructive. All these, COPD, asthma, chronic bronchitis, emphysema. Chronic bronchitis, for your message, you need to remember that is, we have two productive bronchitis 3 months in a row for 2 years consecutive. consecutive years. That is a chronic bronchitis. So chronic bronchitis can lead into COPD alone. Asthma can lead in COPD alone. And emphysema can lead into COPD alone. So combination asthma and chronic bronchitis are going to do the same. They can lead into COPD. There's another one, atelectasia, bronchiectasia, that is not going to be part of this lecture. Okay, so all right, so let's keep going, and one thing I want you to remember is that the way to use the inhaler. Okay, if the inhaler is having corticoids, what you need to do is to wash mouth after inhale. Why? Because the corticoids, as you already know, is number one, anti-inflammatory. So that's why we do that. And before that, before one thing, if you take albuterol and you have this corticoid, which one is going to be used first is the albuterol. Albuterol is going to bronchodilate because it's a beta-2 agonist. And when you have the bronchi very well dilated, you have more options to make the corticoid after it's going to go deeper into your bronchial tree. So number one, albuterol. Number two is going to be the corticoids. So you need to use the spacer. So the spacer has a function. They make to make homogeneous all the spray. So is because if you use the spray directly to the mouth, is when the spray is going to go directly to the mucus. They are not going to go to the bronchi. So that's why it's very useful to use the spacer. Okay. So we have the beta-adrenergic, we have albuterol, all. We have, they are going to stimulate the smooth muscle, okay, beta-2, remember beta-2, two lungs, bronchodilation. Then we have beta-adrenergics, if you have, can produce hypotension, anxiety. Okay. Beta-adrenergic. Indacaterol, that is what I want to go here. Indacaterol is going to be a bronchodilator that is the ultra-long-acting beta-adrenergic agonist, LABA. That is the indacaterol. Okay, so that is being introduced since 2009. Yes, 2009. Anticholinergics, be familiar with the names. Tiotropium, tiotropium, right? So anticholinergics is going to make dry, right? Dry. Xanthines, aminophylline is going to do, first of all, this is medication that is being used when the previous medication, albuterol or corticoids are not, albuterol that is fast effect are not making effect. So some things it's going to be that. So what is the main side effect? Tachycardia, always tachycardia. Tachycardia is going to be the main side effect of the Xanthines. Steroids, mineralocorticoids, please remember here the adrenal gland, this is the medulla, this is the cortex, The cortex, we have the aldosterone, cortisol, and sex hormones, and here in the medulla is going to be the epinephrine. Epinephrine and the norepinephrine that is called the catecholamines. Remember that is a postganglionic sympathetic that is going to be connected to the medulla. That's where it's going to release adrenaline. We have the mineralocorticoids, the aldosterone. Why is called mineralocorticoid? Because it's going to produce, it's going to handle the sodium. Aldosterone, what is doing? Reabsorption of sodium. That's why aldosterone is a mineralocorticoid. And glucocorticoids, the cortisone. Cortisone is a glucocorticoid. Why? Because cortisone elevates the glucose in blood. And remember that produce some nursing consideration for a patient who is diabetic. Okay, so steroid tapering. Steroid tapering, so please, I want you to always remember this. Corticoids are normally our body produces cortisol. Cortisol is the natural human-made by the body, right? Is the cortisol. And the prednisone and the fluticasone, those are derivatives of the cortisol, but are more potent. Okay, so the cortisol is the stress hormone that is going to increase the glucose. That's why the cortisol is going to be higher in the morning and is going to be lower at night. Why in the morning? Because cortisol release glucose into the bloodstream, and that is the moment that we need more, right? We need more in the morning. So that's why the stress hormone cortisol is increased. And and when you are overstressed, the cortisol make you awake, make you still awake or make you awake. So you have too much stress at night, you cannot sleep. Now, when you are giving corticoids as a therapy, so when you are doing corticoids as a therapy, the corticoids need to be trying to give similar as the amount of cortisol that is being secreted normally, physiologically in the body. That's why when you give corticoids by tablets, they are going to give two-thirds, 66% of the dose in the morning and one-third in the afternoon. So that one is going to resemblance the rhythm of the normal cortisol in the body. If you don't do that and you take it at night, it's like you are overstressed, you have too much cortisol, and this is going to make you awake, so you cannot sleep. All right, so let's keep going. Okay. So I think anti-leukotrienes, that is going to cut inflammation. So what we need to remember here is they have about 1 week or 2 weeks to make effect. So that's in general. All right. So that is the mass stabilizers. So I'm going to cut here. I'm going to go to the lecture number 2. And that is about hypertension. Oh, by the way, one more thing I want to let you know before we pass to the next part is about the theophylline. The theophylline. Theophylline is a methylxanthine, right? Theophylline is a methylxanthine, and the methylxanthine theophylline that we already talked that is going to be used when the other medications are not going to make effect. You need to have the recommendation of the recommend the patient not to smoke. Okay, why? Because the theophylline is going to decrease its effect of the theophylline if you smoke. So you need more theophylline in that case. And what is the main side effect? Tachycardia, right? All right, so you can just imagine some patients coming telling you, I have tachycardia, and you say, yes, I have too much tachycardia. So one of the questions is, yes, are you smoking? Yes. So you're taking more dose because you cannot breathe? Yes. So that is the solution, okay? All right, so let's talk about the uh, the hypertension. Okay, give me 1 minute. Okay, so in hypertension, on this lecture, what I want you to be aware that there is a lot of questions in NCLEX for digoxin. Okay, a lot of questions digoxin, nitrates. Okay, nitrates. We have and the ABC, the alphas, the ACE inhibitors, the beta blockers. Okay, so that's what we are going to see now. So, all right, so we are not going to talk about hypertension in general because we already know that. So we have the normal value is going to be 120, and 120 over 80, right? Okay, so we have the pre-stage and stage 2. Perfect. So now we are going to see what is our goal for hypertension. Number 1, So what is the first thing that you're going to do for hypertension? Educate the patient, no? Diet and exercises. What about the diet? Low sodium, right? If you decrease the sodium, you decrease the cardiac output, right? Decrease the volume of water, of blood. Decreasing the volume of the blood, you're going to decrease the cardiac output, decreasing the blood pressure, okay? So now, our goals for hypertension is, and please write down here, I don't have the pen in front of me, not yet, is that we want to have our blood pressure with a patient who has hypertension, period. What is the cause of hypertension? We don't know. Are we going to cure the hypertension? No. Are we going to control the hypertension? Yes. And when you give medication, how you are going to check the effectiveness of the medication. So you need to keep your blood pressure. In that case, the patient who suffer only for hypertension, no other diseases, is be less than 140 over 90. Less than 140 over 90. Less than 140 over 90. Okay? And, and, and for diabetic patient, please, you need to keep the blood pressure. Let me see if I start doing this. If for diabetic patient, okay, sorry, just a moment, please. I'm going to make white. Okay, for diabetic patient, in diabetic patient, the blood pressure should be have your goal in antihypertensive is less than 130 over 80. In no-diabetic patients, in the rest of hypertension, you need to have the blood pressure less than 140 over 90. Okay, so that is about what is the considerations about hypertension. Okay, so so here in hypertension, what you need to remember is what is the main sign when that happens. So this is a killer, silent killer. But the first sign, or if they're very likely to have it, is some headache. Headache. Where is the headache? Mostly in the occipital area. If you go to an ophthalmologist and people doesn't know they're hypertensive, they're going to have some fundoscopy. And fundoscopy, you can have actually the ophthalmologist can see the papilla edema. So what is that? Is the optic disc where the nerve is entering to the eye and is being swollen. That is telling the ophthalmologist that probably you have hypertension. Another way to detect the hypertension. Okay. All right. So let's talk about the treatment. We have A, B, C, D. Just to make it easy, we have the ACE inhibitors, the ARBs, the alpha-1 blockers, beta blockers, but the most commons are going to be these: ACE inhibitors, beta blockers, calcium, and the diuretic. So ABC. ACE inhibitors. What side effects we have? Side effects is going to be angioedema. Remember the angioedema. We have the cough, and we have electrolyte imbalance. What is that? Is hyperkalemia. That is going to happen, hyperkalemia. All right, so when you have cough, only 30% of the population who receiving this is going to have cough. This cough is a dry cough, so what we need is to suspend ACE inhibitors and you pass to ARBs. We have the beta blockers. The beta blockers are going to be beta 1 blocker, right? That is beta 1 blocker. But we have two things: the propranolol, and the atenolol. So there is more, but I'm going to give you the tips of what is NCLEX. Propranolol is going to be a no selective, and atenolol is selective. No selective means if you give beta 1 blocker, they can go to the discussing beta 2 blocker. So they can have beta 2 blocker. What is beta 2 doing? Beta 2 agonist, bronchodilation. But this beta 1 blocker is going to do beta 2 blocker. So that is going to produce bronchoconstriction. So we don't want that. So that is the side effect of beta blocker. And so what is the first sign of this, of bronchoconstriction, is the wheezing. You're going to see here some whistling, right? Or wheezing. Okay, so we are going to see in more details what is going to talk about this. So let's go very fast. Just a moment. I have this interrupting. Okay. Okay, let's keep going. Okay, here we have. Okay, so let's start with the A. We have the ACE inhibitors. The ACE inhibitors, remember everything that is A and B and R, right? So remember this AB. AB is not so effective in African American population. Okay, it's not going to be effective. So we don't use ACE inhibitors or beta blockers. ACE, B, sorry, is beta blockers. So we don't use that in African American. Okay. All right. So in ACE inhibitors, here we have one of the things that is the first dose effect. First dose effect. So please, ACE is the first medication we are looking here, right? So we need to be careful with the first dose effect. First dose effect means that they are going to lead an hypotension. So what to do? So you need at least to observe or the patient stay in a safe place for at least 4 hours under observation, because the first effect can produce hypotension and the patient can have risk for injuries. Okay, so it's not effective in African American, and here we have again. So if you need to hold the prescription, if the blood pressure is less than 100, this 100 is a number that is repeated many times. So when your systolic pressure is less than 100 and you give a medication, you need to observe the medication. In this case, the ACE inhibitors, what they are going to do is the angiotensin convertase enzyme. Remember the kidney, we have the liver, we have the lungs, we have the adrenal gland. So ACE inhibitors is going to inhibit the angiotensin convertase enzyme here. So there is no release of aldosterone at the end. If there is no release of aldosterone, no reabsorption of sodium, the volume go down, cardiac output go down, and blood pressure go down. All right, so let's keep going. So side effects of this is going to be ACE, right? ACE is going to be angioedema, cough, and electrolyte imbalance, the hyperkalemia. So suffix, pril, right? Pril. The favorite, I will say, or at least in my case, is going to use, not for me, but for patients, is going to be the captopril. All right, so let's keep going. So if you have some cough that is only 30% in the ACE inhibitors, you change to ARBs. Okay, they are not going to be effective as in African American. So the suffix is going to be sartan. Okay. All right. So let's keep going. We have the olmesartan, Benicar, that is actually the most common, the olmesartan. We have the aldosterone receptor antagonist that we are going to just mention, the eplerenone. Eplerenone is aldosterone. So remember, the previous ones, we have again kidney, kidney, adrenal gland, we have liver, we have the lungs. Okay, the ACE inhibitors are going to act here. It's going to inactivate the cascade of the renin, aldosterone, angiotensin, aldosterone axis. But here the aldosterone is going, this aldosterone receptor is going to block here. So the kidney is going to not, the receptor in the kidney for aldosterone is going to be blocked. Okay, that is the eplerenone. Alpha 1 blocker is alpha 1 blocker, alpha 1 or alpha 1 agonist is vasoconstrictor. So alpha 1 blocker is going to be vasodilator. So, but this is not the first line of medication. This is going to be used when you have emergency situations of urgency or crisis of hypertension. Okay? All right, so one thing of these side effects is it can produce rebound effect, and the effect is very short. So that means it lasts a short period of time and the pressure go up very fast. So alpha 1 is good to reduce the blood pressure, but alpha 1 blocker is good for reducing the blood pressure, but it's not going to last longer. Here we have the prazosin, the doxazocin. We have alpha 2 agonist, and this is something I want you to remember, please. This is the what we call the clonidine, and the clonidine is what is central action. So what I want you to know about the clonidine, I'm going to write it down. The clonidine, I think E or without clonidine, yes, clonidine is the catapress are going to actually produce one very important effect that is very marked hypotension, hypotension, hypotension. So your nursing considerations with clonidine, that is alpha 2 agonist. Okay. All right. So let's keep going. So here we have the clonidine, the catapress, the methyl dopa, aldomet, and dopamine. Beta blocker. So here, oh, by the way, here the names. Remember, clonidine. Clonidine is the prototype. Then we have the beta blockers, and the beta blockers, a few seen here. A and Bs don't make effect in African American population. The suffix is LOL. So they can produce the propanolol, as we mentioned, is not selective, can produce bronchospasms, and atenolol is selective. So that is not going to happen with atenolol because it's going to be specifically going to beta 1 blocker. Okay, so it's not going to block, beta 2. All right, so here we have beta blockers. What you need to remember is inotropic, and you start to answer me, chronotropic. So we have the inotropic is negative and chronotropic negative. So that means the heart rate go down, the contractility go down. So that means the preload, the afterload is going to go down. Okay, so nursing considerations. So if your blood pressure is less than the systolic pressure, right? Systolic pressure is less than 100, or please, or heart rate is less than 60 beats per minute, you need to consult or contact the prescriber. So we have the propanolol here, see, no selective, and the selective we have the atenolol. So these guys are going to be prototypes. Calcium channel blockers. If you remember the calcium channel blockers, we have here the chart we always talking about, right? This is the sodium here, and this is the calcium. This is the depolarization, repolarization. This is what happened in the cell, in the muscle here, and this is what we have, the depolarization, the contraction. So what's happening with the calcium channel blockers? They are going to block the entry of calcium, so the contraction is going to be not totally blocked, but it's going to diminish the contractility of the heart. So calcium channel blockers. And this is C. Remember A and B, we have ACE inhibitors, beta blockers, including the ARBs, are not for African American population, but C's. Calcium channel blockers, yes, is going to be effective for African American. And pine is going to be the suffix. Nifedipine, amlopidine, verapamil, okay, verapamil, and all these guys, please, all these guys in these calcium channel blockers, as in general, you're going to sorry for that, you're going to see that you need to hold the medication here. So for any hypertensive that you are doing, if your blood pressure is less than 100, if your blood pressure is less than 100, or your heart rate less than 60, you need to stop or and consult your provider, right? All right, so let's keep going. We have the diuretics, that is actually the spironolactone. Spironolactone is going to be, remember TAS are the loop diuretics, TAS, triamcinolone. We have the amiloride, and we have the spironolactone, okay? Sorry, that is the potassium-sparing diuretics. Potassium-sparing diuretics. Okay, so let's keep going for what we angina. Talking about angina, you already know first thing that is the blockage of the coronary arteries, right? So that can produce angina. This angina produces ischemia and then produce the infarction. Infarction that is actually the MI, right? Myocardial infarction. Infarction is, they can be called is what is produced in necrosis of dead tissue. Okay, so that is about this. Let's see. Okay. So we are going to use similar medications. Oh, I need to talk about the clopidogrel, and the clopidogrel is Plavix, is the antiplaquetary agent, right? Antiplaquetary agent. If you remember, we have primary coagulation, secondary coagulation. Primary is the platelets, secondary, this is platelets, this is coagulation factors, the fibrin, right? Fibrin, coagulation factors. These platelets are going to be, they are going to stop the platelet aggregation with aspirin, And here the secondary coagulation, or hemostasia, this is going to have two pathways: the extrinsic pathway and the intrinsic pathway. The extrinsic pathway is the factor, the tissue factor. And what does that mean? That some of the coagulation factors produced by the liver are going to be inside the cell. That is extrinsic factor, is on the cell. Why? Because intrinsic is called what is in blood. All coagulation factors that are in blood. So now, here in the extrinsic factor, we are going to use for anticoagulant, we are going to use the warfarin. And for the intrinsic factor, we are going to use the heparin. Warfarin, we are going to use the PT, it's less than 15 seconds. And for heparin, we are using the PTT, less than 35 seconds. So that is intrinsic factor, heparin PT, that is given by IV or subcutaneous. And warfarin is PO. So just remember, warfarin is, remember the mnemonic, kept the cow. CO, Coumadin, warfarin, W. K means that this warfarin is going to compete with the vitamin K. Vitamin K is participating in that coagulation process. And what is the lab test that we are going to use is the PT. Another lab test associated with the PT is the INR. INR normal values is going to be 1 to 1.5. But when you are taking warfarin as a treatment, your normal values is going to be between 2 to 3. The lab test is a blood sample that is going to be taken in about every 2-3 weeks to see what is the dose or load of the of the warfarin. So that is going to be the about these anticoagulants. Okay, so just to finish this, we need to remember the anticoagulants. You need to always nursing considerations. So nursing considerations is always report what? Report bleeding, any unusual bleeding, right? Gums, etc. Any and this clopidogrel that is antiplatelet, similar to the aspirin, right? So what you need to avoid is to give it with PPI, protein pump inhibitors for antacid. Why? Because that is going to decrease the effect of Plavix. So these three PPs, PPI, Plavix. So Plavix, don't give it with PPI. Okay, we have the, for example, the omeprazole. We have pantoprazole. All those medications are protein pump inhibitor. So that is the Plavix. Okay, so please open eyes, open ears. Okay, so all right, so here the aspirin, we already talked about that. The nitrates. Talking about the nitrates are going to have this potent vasodilation, right? So besides to know about that, you need to remember the main side effect of the nitrates is the decrease of, is the decrease of the blood pressure. So what is going to do? You need to have your nursing considerations. That is the risk for injury, right? So orthostatic hypotension. Don't give with one thing, decrease the preload and the afterload. Okay, so I'm sorry, I see some sign here. Just a moment, I'm going to stop a little bit here. I want to see what is, just a moment. Hemi, can you hear me? Hemi? David, can you hear me? David? Joanne, can you hear me?
Yeah, I can hear you.
I can hear you, Dr. G.
It's not cut it, right? Okay. All right, so let's keep going. So we have the nitrates is going to produce a vasodilation. Oh, I need to, just a moment, I need to put again the encoder, right. Okay, so we need to remember what is preload and what is afterload. Okay, I know that you saw this in search, but preload, what is preload? In simple words, is the blood that is coming to the heart. A little bit more is the blood that is going to fill up the ventricles, right? The cavities. So all the blood is coming, volume is coming to the heart is the preload. And the afterload is the pressure. So afterload is not volume. Afterload is not volume. Afterload is the pressure of the heart. So preload volume, afterload pressure. How much pressure is going to do the heart in order to pump the blood, right? So the more pressure, the more oxygen you consume, right? So and that is going to be, the nitrates is going to produce a vasodilation, and this vasodilation is going to bring more blood to the heart, and that is going to bring more oxygen, and that produce less, let's put it this way, uh, less less work for the heart. All right, so nursing considerations, we need to remove the old patch before the next dose. Another nursing consideration, the hypotension considerations. Another consideration is that if you put in the same place, the patch of the nitroglycerins, for example, in the same part, what is going to produce is irritation of the skin. Irritation of the skin. Avoid hairy areas, because the absorption is going to diminish. Common side effects are going to be lightheadedness, are going to produce headache, and dizziness. And remember always, when you are going to give those nitrates, always check the blood pressure before administer administer the medication. Okay. And the last thing about the nitrates is that how you assess your effectiveness of the medication. How you assess the effectiveness from pain 1 to 10, from 1 to 10. From 1 to 10, you're going to check the patient how he's doing his with the pain. All right, so let's keep going. So you already know that if there is going to be sublingual, you can repeat it after 3-5 minutes. And if the first one doesn't make effect, you need to call 911. All right, so that is about the angina pectoris. All right. All right, so it's heart failure. You need just to remember what is the preload and what is the afterload. So preload is the volume, afterload is the resistance or the pressure, the effort that actually the heart needs to do in order to produce the ejection. Okay, so for heart failure, the treatments are going to be we are going to use ACE inhibitors, dobutamine, and here's an extra, okay? Dobutamine plus epinephrine plus norepinephrine all together are going to be called catecholamines. So far, we used to mention only epinephrine and norepinephrine because dobutamine is mostly going to have adrenergic effect too, but mostly we are talking at this moment so far about epinephrine and norepinephrine. We are going to use ACE inhibitors, and that's what we are going to use for cardiac heart failure. ACE, beta, calcium channels, and diuretics. So the basic, ACE, B, C, and D. Okay, oh, the digoxin. Oh, okay, this is a big thing, okay? Digoxin, I wanted to review a lot about digoxin, okay? Digoxin is important. Why? Because they have two effects, right? Okay, is digital glucosides is digoxin. So it's going to be a negative what? Chronotropic. So that means that it's going to decrease the heart rate. And it's going to be positive what? Inotropic. So it's going to increase the contractility. Okay? So that is going to be used for arrhythmias, and they are going to use for heart failure. Okay? All right, so here we have, first of all, we need to remember that the side effects of the digoxin. First of all, the therapeutic digoxin levels is 0.5 to 2 nanograms per milliliter. 0.5 to 2. So remember your magic 2. So that is going to count. Okay. Now, if you have pulse deficit, pulse rate less than 60, okay, or more than 100, the difference between the heart rate and the pulmonary pulse are often seen in atrial fibrillation. So if you have, for example, the stethoscope, you're going to check for apical pulse. So the heart is never going to be less than the pulse in the radial pulse. So the pumps of the heart is going to be always higher. But if there is a difference, a deficit, or more than 20 or 30, that means that probably you have atrial fibrillation. That is the way that we diagnose atrial fibrillation. Okay, so the first sign of alert of digoxin It's not going to be, it's going to be not the halo, it's going to be, for example, the loss of appetite, and a slightly bradycardia. That is the first signs of the digoxin that are going to be elevated in blood. Okay, so loss of appetite and a slightly bradycardia. So now when you have halos that is a green, red, I see some green or red around, that means that you need to definitely check for lab tests to check the values of digoxin. And when you find the digoxin, when you take the lab test and your potassium is elevated more than 3.5, that is going to use the antidote that is the digoxin immune fab, the Digiban. All right, so you need to hold the treatment or the treatment with digoxin if your pulse rate is less than 60. Okay, so let's keep going. So to the next lecture. All right, so this is lecture number 2. Let's go lecture number 3. Okay, so this is something's wrong with my PowerPoint. Just a moment, please. Okay. All right, talking about dysrhythmias, and this is going to be, believe it or not, it's not high yield in NCLEX, but I'm going to tell you some tips where it's mostly CAM, but it's mostly CAM. All right, so this is okay. So we are going to divide the arrhythmias. So you know that the heart is going to be 60 to 100. Less than 60 is arrhythmia, bradycardia. More than 100, arrhythmia, tachycardia. Tachycardia is what we are going to see mostly now. We have the you know that the heart have nodes that are going to make the heart contract autonomically, right? So we have these nodes are besides the SA node and besides the atrioventricular node, there is some spontaneous nodes appears somehow for some reason in the atriums, and that is above the ventricle. That's why it's called supraventricular. And those autonomic nodes appears in the ventricles are going to be ventricular tachycardia. All right, so for about this, what I want just you to go is about the classification. We have the classification 1. All ones are going to be sodium channels. Risk for hyperkalemia. So we are going to, you know, that sodium is going to be blocked. It's not going to produce the first part of the depolarization of the heart. So that is sodium. So we have 1B, 1A, 1B, and 1C. So class 2 is the second letter of alphabet, beta-adrenergic blocking. Class 3 is we have like 3 legs here, 1, 2, 3 is potassium. Calcium is 4, and the 5 is going to be the adenosine, digoxin, that we are going to see that now. All right, so here we have the pro-dysrhythmic effect. Now remember that any antiarrhythmic can produce more arrhythmias, so that is one of the risks. So channel 1, class 1, sorry, the sodium channel blockers, what we are going to have is the quarter pounder, double quarter pounder, right? So that is the disoparamide, quinidine, and procainamide. So what they like to ask is about the quinidine. Diarrhea is one of the most common side effects of class 1A. So let's remember, if you eat too much double quarter pounder, you have diarrhea. Okay, so that is the class 1. All right, so here we have, we are going to continue with the synchosis is end here, synchosis, chonism, sorry, is the quinidine. Quinidine is going to produce diarrhea, so it's a class 1, right? Diarrhea, tinnitus, and blurred vision. So please be careful with synchronism. Lidocaine is 1B, okay, and the therapeutic levels is 1 to 5 milligrams per liter, but what is important about lidocaine is this, differentiate the lidocaine with the lidocaine who has adrenaline or epinephrine in the bottle, okay, so it's two different situations. Class 1C, we have the sodium channel blockers. So what is the difference with 1B and C? So the number one being used is 1A. If 1A doesn't work, use 1B. If 1B doesn't work, they use 1C. Okay, so that is about so just remember this, the quarter pounder, the double quarter pounder, because the rest is going to be, they're going to tell you the names and they're going to tell you what it's for. Just remember one prototype. Tambocor, flecainamide is 1C. Okay. Beta-2 blocker, okay, do not use for COPD. Obviously, we already know why, right? Because beta blocker can block beta-2, right? So it is a beta-1 blocker, but because it's not selective, can go into lead into beta-2 blocker. All right, so and this is what I want you to remember, please. This is a highly tip. Amiodarone. Amiodarone, what they are doing, the side effect is going to produce they are going to produce edemas. So I didn't put it here. I don't know why, but it's going to produce edemas. Okay, it's accumulation of fluid. The amiodarone, accumulation of fluid. So they are going to be accumulation of fluid. Okay, so I need to put it here. Otherwise, I'm not going to be in peace. So just a moment. Okay, so we have the amiodarone is going to produce fluid accumulation. Okay, so what is the clinical importance about this? Fluid accumulation is going to accumulate any part of the body. So what we have to be careful? The lungs. So if the fluid accumulation, amiodarone, say antiarrhythmic is using amiodarone, look about the lungs. If you hear the stethoscope, you have these crackles. So that means that they are going accumulation of fluid in the lungs. So that is one of the side effects of the amiodarone. Of course, all antiarrhythmics, because they decrease the heart rate. Heart rate means decrease the cardiac output, decrease the blood pressure, and that produces hypotension. QT prolongation and constipation. Blue-gray coloring of the skin. All right, so that is about what I want to talk about. That we was talking already about anticoagulants, I guess, in the previous slides, and let's see. Let me see my note here. All right. So we already talked about that anticoagulants with clopidogrel, with the heparin and the coumarin, right? All right, so that is about this portion. If there's any question, please just let me know. This, again, this is a review. We must study all the lectures. All right, so let's go to our last class, that is the antibiotics. All right, so let's finish this. It's 11:20, so we have about 30 minutes. Let me go here. And thank you for everybody for coming. I really know that you're doing extra effort to come, and I really appreciate it. Okay, so let's go to antibiotics. All right, so definitions, you already know about that. So just review what is the difference between antiseptic and the disinfectant, please, okay? All right, so just again, there's few questions in NCLEX that are going to talk about the difference between empiric, definitive, and prophylactic. Mostly all the antibiotics are going to have similar side effect, that is the nausea, vomiting, and the diarrhea. Vomiting and diarrhea, okay? All right, so now for this, what I want you, a super infection, for example, here is, remember the Clostridium difficile, the C. diff. C. diff super infection. Remember the definition of secondary infection, review your definition of super infection. Okay, so here I want to start, you already know the definition of nephro-hepato ototoxicity. That is the main important, and aminoglucosides. Okay, let's start. I'm going to go very straight and very what we need to remember about aminoglucosides. Ototoxicity and nephrotoxicity. That is one of the main things that you are going to remember. Ototoxicity and nephrotoxicity. One more thing. Ototoxicity and nephrotoxicity, especially their ototoxicity is going to be the tinnitus, right? And when you have, for example, you have quinidine can produce tinnitus. When you have that loop diuretics can produce tinnitus, ototoxicity. Aspirin can produce ototoxicity. Okay, so that is, the myasthenia gravis is important too, but more high yield is going to be the ototoxicity and nephrotoxicity. All right, so aminoglucosides is for gram negative, incompatible with the heparin, okay? Mostly they are going to get together, and please, open eyes, open ears, aminoglucosides are going to give it together with penicillins, These penicillins and aminoglucosides are going to produce a synergy. So penicillin mostly for gram positive, aminoglucosides are for gram negative, so they help each other. A prototype, gentamicin. Streptomycin for next class is where we are going to see is part of the treatment of tuberculosis. That is an aminoglucoside. But the prototype I want you to remember is the gentamicin. Then we have the tetracycline. Tetracycline, what you need to remember is this, right? Too much sun, too much food. So what they are going to be producing photosensitivity or decrease the absorption of the medication. So if you take with medication, this with food, they are going to decrease absorption of the antibiotic. So what you need to do is 1 hour before, right? 1 hour before or 2 hours after the meal, correct? This is one. Okay, so all right. So one see. Oh, here we have the decoloration of the teeth, tetracycline. All right, so let's keep going. Cybox is a very common drug nowadays to use, so you need to get familiar with that. The glycyrcycline is just to remember, Tigasil is tetracycline, okay? And all these weird names that are coming lately mostly are used for MRSA. Okay? All right, so macrolides, you must know this, is erythromycin. Oh, by the way, tetracycline is a broad spectrum, positive and negative. But we don't use that often, tetracycline. Why? Because bacteria, they can produce resistance easily to tetracyclines. So that's why it's not first line. Even though that is a broad spectrum, it's an excellent antibiotic for some specific bacteria, but we don't abuse them because they can produce resistance very easily. Macrolides is the erythromycin. Erythromycin, you need to remember, skin problems, respiratory problems. Okay? Tetracycline is going to be used, for example, for atypical pneumonias, are going to be for acne in the face, comedones, and the young people, they're going to use tetracycline. Macrolides, we have skin infection for staphylococcus, for streptococcus. We have the citromycin, clarithromycin. Those are using for upper and lower upper and lower respiratory infections. All right, so very important. The first antibiotic that is produces allergies most commonly is the penicillin. If you cannot use penicillin, you cannot use neither cephalosporins, because cephalosporins and penicillins are beta-lactams, both of them. So they can have cross reaction, 10%. So if you have allergy to penicillin, don't give cephalosporins. So the second line is going to be the macrolides, the erythromycin, azithromycin, and the clarithromycin. Okay. All right. So here we have that, remember, any antibiotic who is broad spectrum, and please, open eyes, open ears, they can actually increase the activity of warfarin. Sounds complicated, it's not. Why? Because if you have broad spectrum antibiotic, they can actually sweep out the flora, diminishing the vitamin K. And that's why if you give Coumadin is going to even block more the vitamin K. So you have risk for bleeding. Makes sense. All right, so let's keep going. All right. The beta-lactams. Beta-lactams are a ring, right? A ring that is composed the antibiotic. We have the penicillins and cephalosporins. Monomolactams are excellent, but we are not going to talk about that much. Penicillins and cephalosporins. So penicillins and cephalosporins are going to have, especially the penicillins, are going to be used with some medication that is called the probenecid. Where is the probenecid? Probenecid. Probenecid. It's important to know that because that is an acidifier of the urine. Probenecid is an acidifier of the urine, and this probenecid, what is doing with the urine is acid, is going to diminish the excretion of the penicillin, so making the penicillin stay longer in your body. Okay, so that is important. All right, so we are going to keep going. We have cephalosporins. We have first generation, second, third, and fourth generation. So if I ask you, if I have a bacteria who is gram-positive, which cephalosporin are going to give? All right, so you're not going to give the big gun. You're going to give the specific gun that is the first generation, the gram-positive. So you always try to avoid unnecessary use for broad spectrum, because what are the consequences? C. diff. At the end, they can erase or sweep out the flora of the intestine. And it's not the only flora we have, right? We have flora in the conjunctiva, in the skin, in the respiratory tract, etc. Okay? Okay, so let's keep going here with the antifolates. We have the sulfas. And talking about the sulfas, what they have is, we are going to see the photosensitivity, and this is going to mostly use for sulfas is going to be used mostly for UTIs. Can you excuse me 1 minute, please? Okay, sorry for that. So let's keep going. So here we have, in general, the quinolones, please. In the quinolones, we have the fluoroquinolones. The fluoroquinolones are going to be the norfloxacin, ciprofloxacin, and the levofloxacin, levaquin. This is very common. So what is important about the quinolones, this is a broad spectrum too. Penicillins is broad spectrum. Cephalosporins, first generation, positive. Second generation, positive and negative. Third generation, positive, negative, negative. And the fourth generation is going to be very broad spectrum. We have fifth generation that are actually just them being used in veterinary, and now it's going to use in humans. And now we have the quinolones. The quinolones, we have generations 2, first, second, third generation. That is not really asking as often. But what we need to remember is the side effects. Quinolones is a broad spectrum too. Should not be prescribed in patients younger than 18 years old or more than 60. Risk, please, 5 stars, 3 moons, whatever you want to put here. So please remark here, risk of muscular skeletal disorders in patients using corticoids. So be careful with that. They can produce some rupture of tendons. Okay. Okay. So in conclusion, what I want to talk about. Oh, there is one more thing that is really important is the vancomycin. Vancomycin is huge. Okay. So vancomycin, I really want you to have some time to read it with some time. And the first thing I want you to remember, vancomycin is always the first choice for MRSA. MRSA. Okay, they're going to be used for C. diff too, but MRSA is, you have MRSA, vancomycin. So what is important here is the levels of vancomycin in blood is 2 to 20. Okay, so those are part of your magic numbers, right? Vancomycin is 10 to 20, sorry. Toxicity is more than 20. Okay, so if you know this chart, lithium is what is coming later, phenytoin is coming later, so we already saw digoxin, thiophanine, vancomycin. And if you know this, you are going to kill many questions in the NCLEX, for sure. So, and the other thing is the red man syndrome. Red man syndrome or red neck syndrome, sometimes they call it like that. So what they can produce is a thrombophlebitis. So if you infuse is being infused the vancomycin so very fast, they are going to literally burn the vessel, and they are going to collapse. And the collapse can produce inflammation. Narrow the lumen, turbulent flow, slow down the flow, and produce a clot. So one thing I want you to remember about this is that they need to be administered more than 1 hour, more than 60 minutes. Okay, it's for MRSA, and that is going to be the 10 to 20 toxicity levels. Okay, my friends, thank you so much. I think we finished a general review. Again, this was not pretending to do a lecture of all the that we did in the previous weeks. So it's just a review of what is general highlights of pharmacology too. All right. So if there is any questions, please.
Thanks, Dr. G.
Okay, David. Thank you so much.
Thank you, Dr. G.
Thank you. That is helping a little bit. So I will see you on Friday. David, thank you so much. Hemi, thank you so much. Joanne, thank you so much, Joanne. May thank you so much too. For all
Thank
of
you,
you.
Dr. G.
All right, muchas gracias. I will see you next time. Gracias.
Thanks, Dr. G. See you later.
See you later.